Picture a patient at baseline. Oxygen saturation, 98%. Respiratory rate, 16 breaths per minute. Heart rate, 72. Every number sitting comfortably inside normal range. Auscultation clear, chest x-ray showing no active pathology. This is what physiological stability looks like. But behind these numbers lies an entire diagnostic universe, because the moment any one of these values drifts, your body starts telling a story, and clinicians are trained to read it. This video is a deep dive into the clinical pathophysiology, semiology, and diagnostic integration of respiratory disease. How doctors take a patient's history, listen to their lungs, examine their posture, interpret their sputum, and run targeted tests to land on a precise diagnosis. We'll explore everything from the brainstem's control over your breathing drive to the 6 life-threatening causes of chest pain, to the acoustic fingerprints of collapsed airways, all the way through to ARDS and autoimmune lung disease. By the end, you'll understand how seemingly small clinical clues, a wheeze, a color of mucus, a single lab value, combine into a complete diagnostic picture. Let's begin where respiratory control itself begins, deep inside the brain.
Your breathing rate isn't random. It's continuously regulated by a tightly controlled feedback loop. At the center sits the central medullary drive, where receptors in the ventrolateral medulla detect interstitial pH changes, essentially using pH as an indirect surrogate for carbon dioxide levels crossing the blood-brain barrier. As CO2 rises, pH drops, and the medulla increases ventilation to compensate. But the brain isn't working alone. Out in your blood vessels, peripheral chemoreceptors sit in the carotid bodies and aortic arch, acting as your body's hypoxemia rapid response team. These receptors stay relatively quiet until oxygen levels fall below roughly 60 millimeters of mercury. And when that threshold is crossed, they trigger a sudden, dramatic, non-linear surge in ventilation. Meanwhile, mechanical feedback fine-tunes the whole system. The Herring-Brewer reflex uses pulmonary stretch receptors to terminate inspiration before the alveoli overinflate. And juxtacapillary receptors, known as J receptors, sit right beside the pulmonary capillaries, becoming activated by fluid accumulation, such as in pulmonary edema, triggering that classic rapid, shallow breathing pattern seen in heart failure patients.
Before any test is ordered, the clinical history alone narrows the diagnosis dramatically. Timing matters first. A cough lasting 8 weeks or less is classified as acute, often just a self-limiting viral infection. But push past 8 weeks, and you're now looking at chronic disease, pointing towards structural lung changes or persistent inflammation. Next comes risk quantification, most famously through the pack-year metric, calculated by taking cigarettes smoked per day, dividing by 20, then multiplying by total years smoked. This single number is one of the strongest predictors of lung cancer and COPD risk in clinical medicine. Environmental exposures matter too. Occupational exposures can have a disease latency of up to 20 years before symptoms even appear, while domestic exposures, like humidifiers, stagnant water, or airborne mold, can trigger hypersensitivity reactions far sooner. Temperature assessment also plays a role, with rectal measurement remaining the clinical gold standard. And finally, medication history is critical. ACE inhibitors, commonly prescribed for blood pressure, block bradykinin breakdown in the upper airway, frequently causing a persistent, dry, medication-induced cough that's easy to misdiagnose.
What comes up when a patient coughs can be remarkably diagnostic. In acute illness, sputum purulence is actually a fairly weak indicator of bacterial infection. But in chronic conditions like bronchiectasis, baseline purulence becomes a validated prognostic biomarker tied directly to mortality risk. Mucoid sputum, clear and thick, typically reflects a healthy baseline, allergies, or an uncomplicated viral infection, driven simply by mucus overproduction. Purulent sputum takes on a green hue, caused by myeloperoxidase released from recruited neutrophils fighting active bacterial infection. Push further into severe purulent sputum, and you're often looking at progressive bronchiectasis or chronic colonization by Pseudomonas aeruginosa, signaling cellular breakdown and tissue necrosis. Then come the pathognomonic colors, findings so specific they almost diagnose the disease on sight. Rust-colored sputum is a classic sign of pneumococcal pneumonia, caused by Streptococcus pneumoniae. Currant jelly sputum, thick, dark red, and gelatinous, is virtually diagnostic for Klebsiella pneumoniae lobar pneumonia. And pink, frothy sputum signals acute cardiogenic pulmonary edema, where protein-rich fluid leaks out and mixes with alveolar surfactant.
Not all chest pain is created equal, and the nervous system anatomy explains exactly why. Non-pleuritic pain, typically diffuse, crushing pressure like that of a heart attack, remains completely unaffected by your breathing cycle because it doesn't originate from pleural tissue at all. Pleuritic pain is different. It's sharp, stabbing, and dramatically worsens with inspiration or coughing. The reason lies in a fascinating anatomical detail. The visceral pleura, which directly covers the lung, has no pain receptors whatsoever. But the parietal pleura, lining the chest wall, is heavily innervated, which is why inflammation there produces such sharp, localized pain. This pain can also refer to other areas. Irritation along the intercostal nerves radiates pain to the corresponding dermatome on the chest wall, while irritation of the phrenic nerve, which supplies the diaphragm, can refer pain all the way up to the neck or shoulder. Clinically, 6 conditions represent genuine pleuritic emergencies: pulmonary embolism, myocardial infarction, pericarditis, which characteristically worsens lying flat and improves leaning forward, aortic dissection, often described as a tearing sensation, pneumonia, and pneumothorax. Misidentifying any of these can be fatal, which is why precise pain characterization is a critical first diagnostic step.
Long before any test results come back, a trained eye can detect respiratory distress just by looking at the patient. At the head and neck, nasal flaring is a reflex mechanism the body uses to reduce resistance in the upper airway during labored breathing. Central cyanosis, a bluish discoloration of mucous membranes, indicates oxygen saturation has dropped below roughly 85%, a genuine red flag. Moving to the chest and trunk, intercostal retractions, visible inward collapsing of skin between the ribs, signal severe obstruction to airflow. Over time, conditions like emphysema can produce a barrel chest, where chronic alveolar hyperinflation literally reshapes the thoracic cavity, pushing the front-to-back diameter ratio toward a 1-to-1 shape instead of the normal flatter profile. Accessory muscle use is another major clue. Recruitment of the sternocleidomastoid and scalene muscles in the neck signals the body is generating extra negative intrapleural pressure just to move air. And in the extremities, digital clubbing, enlargement of the fingertips, develops from chronic hypoxia, driving the release of growth factors like PDGF and VEGF. Patients in severe distress often adopt tripod positioning, bracing their arms forward to optimize the leverage of their chest muscles.
A stethoscope reveals far more than most people realize because the location and pitch of abnormal lung sounds map directly to where in the airway the problem lies. Stridor is a high-pitched monophonic whistle, predominantly heard during inspiration, caused by high-velocity airflow squeezing through a severely narrowed upper airway. Think croup or a foreign body lodged in the trachea. Move deeper and rhonchi appear. Low-pitched, coarse, snoring-like sounds in the central bronchi, typically caused by air moving through thick mucus, and notably, these often clear or change after coughing. Further still, in the smaller bronchioles, wheezing develops, a musical polyphonic squeaking sound, predominantly heard on expiration, caused by turbulent airflow through inflamed bronchospastic airways, classically heard in asthma and COPD. In the most distal, non-cartilaginous airways, you'll hear squeaks, brief, high-pitched, late inspiratory sounds from small airways snapping open. And finally, at the alveolar level, crackles, or rails, produce that distinctive, discontinuous, explosive popping sound, often compared to Velcro being pulled apart, caused by the sudden reopening of collapsed, fluid-filled, or fibrotic airways during inspiration.
Sound transmission through lung tissue changes dramatically depending on what's filling the space, and this principle is incredibly useful diagnostically. In a normal, healthy, air-filled lung, sound waves naturally fade and dampen as they travel through aerated tissue. But when lung tissue becomes consolidated, filled with inflammatory exudate, as in pneumonia, sound transmission actually improves, becoming thicker, amplified, and traveling with much greater clarity. This creates several detectable signs. Tactile fremitus, where vibrations felt on the chest wall increase over consolidated tissue. Bronchophony, where a spoken 99 transmits unusually loud and clear. Whispered pectoriloquy, where even whispered words become distinctly audible. And egophony, where consolidated lung acts like a strange acoustic filter, transforming a spoken E sound into something resembling a nasal bleeding A. But when fluid fills the pleural space itself, sound transmission is completely blocked. Waves simply hit the fluid layer and bounce back, producing absent or muffled breath sounds. Two other distinctive findings round out pleural acoustics: a pleural friction rub, a non-musical creaking sound, like walking on fresh snow, caused by inflamed pleural surfaces grating together, unaffected by coughing, and Hammond's sign, a crunching sound synchronized with the heartbeat rather than breathing, a hallmark of pneumonia mostinum.
When the diaphragm becomes severely fatigued, something dangerous happens called paradoxical breathing. Normally, the diaphragm contracts downward during inspiration, but in severe fatigue, active contraction fails entirely, and the high negative pressure generated by accessory neck muscles instead passively pulls the now flaccid diaphragm upward, actually sucking the abdominal wall inward during inspiration, the exact opposite of normal mechanics. This mechanical failure sets off a dangerous, self-reinforcing psychophysiological panic loop. It begins with mechanical inefficiency and severe dyspnea, which triggers alveolar hypoventilation and rapid shallow breathing. This rapid breathing then causes respiratory alkalosis, as carbon dioxide is blown off too quickly. That alkalosis alters ionized calcium levels, producing cerebral vasoconstriction, the cause of dizziness, tingling, and muscle spasms patients often report. This neurological distress then triggers systemic panic, which paradoxically escalates motor drive even further and accelerates catastrophic respiratory muscle fatigue, feeding right back into the original mechanical inefficiency. Understanding this loop is critical clinically because patients in this cycle need calm, controlled intervention, not just reassurance, since the spiral is physiological, not purely psychological.
Spirometry is one of the most powerful tools for classifying respiratory disease into three distinct mechanical categories. Obstructive disorders, like asthma and COPD, involve increased airway resistance, premature airway closure, and loss of elastic lung recoil. On spirometry, this produces a decreased FEV1 to FVC ratio, alongside increased functional residual capacity and residual volume, driven by chronic air trapping inside the lungs. Restrictive disorders, such as pulmonary fibrosis or chest wall conditions like kyphoscoliosis, work completely differently. Here, lung compliance is reduced, meaning the lung tissue itself becomes stiff, or in extrapulmonary cases, the chest wall itself loses compliance. This produces a normal or even increased FEV1 to FVC ratio, but with both forced vital capacity and total lung capacity clearly decreased. Then there's vascular pathology, conditions like pulmonary embolism or pulmonary arterial hypertension, which behaves completely differently from the other two categories. Here, airway and lung tissue mechanics remain entirely normal, and spirometry volumes stay unaffected. The defect lies purely in the blood vessels themselves, which is why the diagnostic clue isn't airflow at all. It's a sharply decreased DLCO, the lung's gas diffusion capacity, revealing that blood vessels are either destroyed or obstructed.
Certain lung diseases are triggered by very specific environmental exposures, and recognizing the trigger often reveals the diagnosis instantly. Hypersensitivity pneumonitis develops when the immune system becomes sensitized to inhaled antigens.
Exposure to wheat dust and certain fungi, especially Aspergillus and Saccharopolyspora species, causes farmer's lung, typically from moldy hay or compost. Exposure to avian proteins from pigeons or poultry causes bird fancier's lung. And inhaling mycobacteria-contaminated aerosols from indoor pools causes a condition known quite literally as hot tub lung. Beyond environmental antigens, certain medications themselves can directly injure lung tissue. Drugs like amiodarone, bleomycin, and cyclophosphamide can trigger diffuse alveolar damage, presenting clinically just like ARDS, acute respiratory distress syndrome, even though the underlying cause is pharmacological, not infectious. Separately, anticoagulant medications can trigger diffuse alveolar hemorrhage, presenting with severe hemoptysis, coughing up blood, alongside systemic anemia from ongoing blood loss. Recognizing these toxin and antigen-driven patterns is essential because removing the trigger is often the single most important step in treatment.
Some of the most severe lung diseases aren't caused by infection or toxins at all. They're driven by the immune system attacking the body's own tissue. Each autoantibody creates a remarkably specific clinical fingerprint. Anti-GBM antibodies targeting alpha-3 type 4 collagen cause Goodpasture syndrome, producing necrotizing inflammation of the alveolar capillaries that leads directly to diffuse alveolar hemorrhage. C-ANCA antibodies targeting an enzyme called proteinase 3 cause granulomatosis with polyangiitis, formerly known as Wegener's, a necrotizing small vessel vasculitis that produces cavitary lung nodules and hemoptysis. P-ANCA antibodies, when combined with peripheral eosinophilia, point toward EGPA, also called Churg-Strauss syndrome, characterized by severe asthma alongside eosinophil-rich granulomatous inflammation throughout the respiratory tract. And ANA, or anti-dsDNA antibodies, are markers for systemic lupus erythematosus, where immune complexes deposit in the pleura, causing lupus pleuritis, serositis, and recurrent pleural effusions. These antibody-disease relationships aren't just academic trivia. In clinical practice, ordering the right serology test based on the right clinical suspicion can confirm a life-altering diagnosis in days rather than months.
Acute respiratory distress syndrome, or ARDS, represents one of the most severe forms of lung injury, and it unfolds in 3 distinct, progressive stages. It begins with a major systemic trigger, sepsis or trauma, causing a massive influx of neutrophils into the lung. These cells release destructive proteases and reactive oxygen species that destroy both type 1 and type 2 pneumocytes, the cells lining the alveoli. This destroys surfactant production, causing widespread alveolar collapse, known as atelectasis. In stage 1, spanning roughly the first week, the exudative phase dominates. The alveolo-capillary barrier breaks down completely. Protein-rich fluid floods into the alveoli, and hyaline membranes form, clinically presenting as severe refractory hypoxemia that's extremely difficult to correct. Stage 2, occurring between roughly 1 and 3 weeks, is the proliferative phase. The body attempts repair through type 2 pneumocyte proliferation and early interstitial collagen deposition. If the insult continues beyond 3 weeks, stage 3 develops, the fibrotic phase, where the lung's normal architecture is permanently replaced by dense fibrosis, resulting in severe loss of lung compliance and often chronic pulmonary hypertension. This progression explains why early ARDS intervention is so clinically critical. Once fibrosis sets in, the damage becomes largely irreversible.
Once clinical suspicion is established, objective testing confirms the precise anatomical defect. Imaging plays a central role. A chest X-ray remains the first-line screening tool, useful for pneumonia, pneumothorax, and ARDS infiltrates. CT angiography is the gold standard for identifying pulmonary embolism and aortic dissection. High-resolution CT becomes essential for mapping interstitial lung disease and detecting subtle early fibrosis. And a ventilation perfusion scan can detect perfusion mismatches consistent with pulmonary embolism when contrast-based CT angiography is contraindicated. Laboratory testing complements imaging perfectly.
Arterial blood gas analysis remains the gold standard for assessing gas exchange and acid-base status through the AA gradient. D-dimer testing carries a high negative predictive value, making it excellent for ruling out venous thromboembolism. And BNP or NT-proBNP levels help distinguish cardiogenic heart failure from non-cardiogenic causes of pulmonary edema, like ARDS. Finally, when pleural effusions are present, diagnostic thoracentesis becomes necessary, applying Light's criteria, based on protein and LDH ratios, to classify fluid as transudative, driven by hydrostatic pressure changes like heart failure, or exudative, driven by inflammation and increased capillary permeability, as seen in pneumonia or malignancy.
Let's bring everything together into one unified diagnostic framework, what we can call the diagnostic funnel. Layer 1 is the encounter, gathering subjective history, establishing the timeline, calculating pack years, and stratifying environmental risk exposure. Layer 2 is the mechanics, bedside semiology, visually inspecting the patient's work of breathing, chest wall symmetry, and carefully mapping airflow and pleural sounds through auscultation. Layer 3 is the phenotype, using spirometric metrics to classify disease as obstructive, restrictive, or vascular in nature. And Layer 4 is the confirmation, targeted integration of advanced imaging like HRCT or CT angiography alongside specific autoimmune serologies like ANCA or anti-GBM testing. When these 4 layers funnel together, they produce the outcome that matters most, a definitive pathological diagnosis, enabling optimized respiratory mechanics, accurate prognostication, and precisely targeted treatment. This is the real architecture of clinical respiratory medicine. Not a single test, but a structured, layered process of reasoning, where history, physical examination, physiology, and laboratory science combine into one coherent, life-saving diagnostic picture.